Be great. We'll be live in about 10 seconds, guys.
How are you all?
All right, we're live on YouTube and Instagram.
Excellent. All right, it's 4 o'clock. Why don't we get started then? Welcome everyone to another edition of Tumor Talk. This is the collaborative effort between Lenox Hill Neurosurgery and the Journal of Neuro-Oncology, where we highlight recent publications and talk about, why the research was done, what the results were, and the relevance to the field of neuro-oncology. And so we're pleased to have with us a return of Yoshua Eskenazi. He's been on before, and with him is Tony Patras. I'm going to let you guys introduce yourselves and talk to us a little bit today about our topic, tumor recurrence, treatment-related changes, and what it all means. Really fascinating topic. So pleased to have you guys with us.
Yeah, thank you for having us. Yeah, so my name is Tony Patras. I'm a fourth-year medical student at McGovern Medical School down in Houston at UT Health at Memorial Hermann. I'm applying into neurosurgery, and I've been working with Dr. Eskenazi for about 4 years in medical school, and this is one of the projects we've been kind of undertaking for that time period. So.
Excellent. Yoshua, you there?
Yes, I'm here.
Oh, great. You want to just introduce yourself and what?
Okay, well, hi. Thank you, everyone. I'm Joshua Eskenazi. Thank you, Randy and Dr. Sheehan and Del for the invitation. I'm a neurosurgeon. I work at UT Houston, and we're going to be presenting some of the work that we've done over the last few years. And Anthony Patras is a fourth-year medical student who's going to be presenting his slides.
Excellent. All right, Tony, dive right in.
All right. Yeah. So as mentioned, this is our paper recently published in the Journal of Neuro-Oncology titled Tumor Recurrence or Treatment-Related Changes in Patients with GBM. Does pathology predict outcomes? A lot of people are probably familiar with the term radiation necrosis. Recently, that field's kind of drifted more towards treatment-related changes, and that's the terminology we use throughout our manual. So despite surgical resection and chemoradiation, almost all patients with GBM invariably recur with worsening of radiological appearance. Conventional imaging is limited in differentiating tumor recurrence from treatment-related changes. And unfortunately, clinical symptoms are often similar, therefore re-resection is often needed to get any indication on what's actually going on. There's been studies in the past that have assessed the relationship between re-resection histopathology and overall survival. But it's very important to note that there is currently a lack of consensus or guidelines to interpret histopathological samples from GBM recurrence. And this lack of consensus represents a major challenge in the neuro-oncology community, and there is an urgent need to address this problem. Additionally, there's also a lack of comprehensive data incorporating mutational profiles that may predict treatment-related changes and its prognostic significance. So in our study, clinical radiographic and histological information was compiled from 675 patients diagnosed with GBM between 2005 and 2017 at the Memorial Hermann Health System. Of those, 137 underwent re-resection for recurrence. And here we have 22 patients who would be diagnosed with treatment-related changes based on their histopathology, while 115 would be for tumor progression. Of those 22 patients with treatment-related changes, we would have mutational information for 8 of them at their primary resection, and then 60 in the tumor progression category. So all cases were classified as treatment-related changes or tumor recurrence according to the pathology report. Cases in which any evidence of tumor was identified, in addition to any treatment-related changes, we placed in the tumor recurrence category for analysis. Pathology reports in which recurrent or residual glioma was the diagnosis were also classified as recurrence. And recurrent glioma was diagnosed as robust tumor regrowth with dense cellularity and evidence of proliferative activity, while residual glioma was diagnosed as tissue with treatment-related effects such as marked nuclear atypia with low cellularity and without any signs of proliferation. Treatment-related changes were defined as a histological evidence of vascular hyalinization and or necrosis and no evidence of mitotically active tumor. A snippet of one of the tables in the paper. The rest of the table that I'm not showing just shows radiological postoperative changes and postoperative treatments, and they were identical between the two groups. But I show this here that it's important to note that several patients in the treatment-related changes group, about 32% of them, received no further adjuvant chemotherapy following a reoperation. And we also noticed a significant decrease in radiotherapy in that group, as well as tumor treating fields following their second resection. Additionally, 18% of patients with tumor recurrence underwent targeted therapies or clinical trial enrollment, compared to 5% in the treatment-related changes. So that begs the question whether or not these patients deemed to have treatment-related changes should continue aggressive regimens, which may potentially improve outcomes. Further studies are required to determine to what extent histological evaluation should inform treatment-related decisions at reoperation and preclude patients from enrolling in clinical trials. So here we saw these two survival curves that we saw no difference in progression-free survival in our two groups. It's also worth noticing that the average progression-free survival was approximately 6 months, which is outside of that kind of pseudo-progression criteria, which is usually within the first 3 months following re-resection. There was also no difference between the groups in the time to, from primary to re-resection, with about a 7-month time period passing. I think the most important finding, and similar to other studies, is that histopathology was not predictive of overall survival in our cohort. And again, as I mentioned, these are consistent with previous smaller reports, which found no survival difference, depending on whatever histological criteria those papers used at disease recurrence. And additionally, there was no changes in overall survival following second surgery. So out of the 137 patients that underwent re-resection, 68 had next-gen sequencing from their primary section, 8 of which would be classified later as treatment-related changes, while 60 would be classified as tumor recurrence. No mutation profile was found to predispose to a specific histologic finding after recurrence after multiple testing adjustments. Here, this table shows the most common genetic alterations and their relationship with treatment-related changes and recurrence. It's worth pointing out, though, even though that we didn't find any significant difference in any of these groups, some of these genes, such as TERT-P and P10, have previously been shown to have, depending on the mutation they have, to make either patients more or less susceptible to radiation therapy. So further studies with larger cohorts should explore the possibility of relationship with genes like this and the development of treatment-related changes in the future. Here we just show one of the oncoplots from our paper. This is from the primary resection, just showing the different genes. And our next-gen sequencing Foundation 1 report sequenced 324 genes. And some of these patients also had sequencing done following their re-resection. And in the paper, we note that there really wasn't much change in their driver mutations at primary and re-resection. So in summary, our paper shows that, pathology at recurrence was not predictive of overall survival, and we did not identify clinical or molecular factors that predisposed to radiation necrosis. It is important to note, though, that individual genetic susceptibility could contribute to radiation changes or treatment-related changes and should be further explored. Recently, there was a single nucleotide polymorphism, CPAP128, was found to be associated with an increased risk of temporal lobe necrosis in patients undergoing radiation therapy for nasopharyngeal carcinoma, which gives us some evidence that there is individual susceptibility out there. Additionally, de-escalation of therapies in the treatment-related changes group could potentially contribute to the lack of improved survival. We also recognize that there's an urgent need to develop better imaging biomarkers or potential circulating biomarkers to identify necrosis non-invasively. And this will come with improvement in imaging modalities, such as like 3D arterial spin labeling. So where do we go from here? In 2019, a position paper from the RANO group, which is a recurrent glioma pathway working group, it's a multi-institutional assessment of the analytical criteria and the evaluation of recurrent glioma specimens, began to address these issues. What they're trying to put forth is robust standards for classifying recurrent glioma, as they do not exist currently. Far too often, diagnoses such as recurrent and residual high-grade glioma are listed, and minimal molecular testing is performed on those specimens. So in their position paper that I just showed, they lay out some different areas that they're working on to improve this. They highly recommend avoiding the term recurrent versus residual glioma, and in doing so, we have to rigorously define what recurrent versus residual glioma is. We can do this by comparing our re-resection tissue to primary resection, developing a quantitative criteria for proliferative activity, tumor cellularity, how much viable tumor content there is, and what treatment effect and reactive changes are present. They suggest that residual glioma should be employed to specify glioma cells showing unequivocal treatment-related effects without signs of proliferation, and recurrent should be reserved for robust tumor regrowth. Additionally, when it comes to specimen sampling, extent of submission and resection should be documented, and we should correlate where tissue resected from correlates to radiographical features and identify infiltrating margin involvements. And lastly, detailed molecular analysis can be performed on these re-resected tissue to determine which tumor cells can be drivers of recurrence compared to the primary resected tissue to look at changes. RNA sequencing has showed early promise in identifying transcriptional signatures that correlate with recurrence patterns, and liquid biopsies using CSF and plasma show early promise as well. We must consider that all patients may have some proportion of recurrent disease that fails to be assessed by histology, and not all tissue that is resected is sent to pathology for information. This sampling bias may lead to ill-informed decisions, which may impact further management strategies, providing a false sense of disease control. And this is the paper that this work was pulled from that we recently published in the Journal of Neuro-Oncology.
Great work, Tony.
Yeah, it's great. That's really cool stuff.
Randy,
do you have any questions?
Yeah, I mean, you know, it's very interesting to think about this in this regards. And it's obviously a problem that, you know, in training, you don't realize how much it's going to actually influence your practice. And then you're in practice and you're looking at scans and you hear about it all the time. And all of a sudden you're making decisions with people and you have no idea, right? You don't know if this is treatment related change. You don't know if it's recurrent tumor. You're relying on a multidisciplinary team on criteria that's very much imperfect to make decisions. And it really does affect, I think, every day of, you know, a neuro-oncologist, you know, practice, without a doubt. And so I think it's an important field to focus on and to develop, you know, algorithms and parameters for. My question though is, you know, how has this changed what you guys are doing? So you guys obviously are looking at pathology and recurrence and MRIs now. How is this influencing your day-to-day practice? Kind of these results, are you being more stringent now with what you call recurrent tumor? Has that been employed kind of system-wide for you or just personally?
Oh, thank you. I can, I guess I can touch on that. But yeah, thank you, everybody. Thank you, Dr. Sheehan. And, you know, as you mentioned, Randy, it's a very common problem that we all have in our tumor boards. And every week we're seeing the pathology report and we're not sure what we're seeing. So the pathologists may report, well, there's some tumor, there's a little bit of tumor, there's treatment-related changes, and then some even go into percentages. And what does that mean? Because obviously we don't want to operate on a patient and the path is going to come back saying there's no tumor, because then we really didn't help the patient at all. So we're just taking the patient, you know, putting him through a big operation, stopping some of the chemotherapies or any other option. So the question is, what do we do? And many of the prior studies have been small. So the issue is, it is a big problem everywhere. And we wanted to see if we could find initially some molecular markers that could potentially predict, or if we could find anything that would predict one or the other one. As you know, it's quite challenging with imaging studies to take or make any decisions. But we've looked at recent papers, and I believe one at JNO2, where there's no correlation and there's significant differences in the reporting between every pathologist. So if you give the same case to 10 pathologists, some of them are going to say, well, there's some tumor, there's no tumor. And the main problem is the oncologist that is not going to know how to manage the patient. And we as neurosurgeons, we're in the operating room, we're seeing the images, and as a multidisciplinary team, how is this going to change? And in reality, I think that the thing that is most exciting is the RANO group, which is led by Jason Hughes from MD Anderson. And it's a very large group. And now, you know, we're having these monthly meetings where we're looking at sampling bias and making sure that the majority of the tumor is sent to the pathologist, potentially looking at molecular markers, not only in a single center, but in multiple centers, obviously in retrospective fashion. So it's quite important to make decisions based on what the pathologist is seeing. So if you're not seeing any tumor on the path, that may just say that either you didn't sample the tumor because it's not really making a difference in survival, or the treatment is working. And as we saw in our patients, the majority of those patients were not being treated more aggressively. And that may be a problem, because if the treatment is working, then you should probably not discontinue the treatment, or if it's past the 6-month period and they're not taking Timodar anymore, well, maybe they should restart it. So I think we saw some de-escalation of therapies that could have potentially affected the survival in that group of patients. But
I think it's very tricky too, because it's obviously, I feel like we all believe that there's still tumor there, right? We know that there are tumor cells and they're still there. And you guys have shown that, maybe treatment is the right thing to do, continue to stay on to improve these outcomes since it's not changing. But where does the indication for surgery come in then? At some point, we know that second resection, removal of contrast enhancing disease, extends survival, quality of life, progression-free survival a second time, or at least, we believe it. That's why we do it. But if you're not sure, is there an indication to even go back in for the second surgery in the absence of symptoms? Should we just pursue further treatment?
Yeah, I think that's a great question. And based on what you're saying, many of the studies, and I'm not going to say all of the studies, but the majority of the studies have demonstrated that a second operation helps. There's a paper in JNS from Memorial Sloan Kettering that showed a lead time bias where it didn't help. And the problem with the majority of the studies that have been done previously is that the time of survival was taken from the time of the second surgery to the time of death, rather than taking it from the time of diagnosis.
Yeah.
So if you have a patient that is living 18 months, but in reality had a recurrence at 17 months, then the surgery only extended survival 1 month. If he had his recurrence at 5 months, then the surgery extended the survival 15 months. So I think it's important to know or identify which groups of patients may benefit from re-resection. And I don't think that they all benefit from re-resection. Most of the prior studies have been done with glioblastoma, which has changed. And we know that IDH wild-type tumors are different. And even within the IDH wild-type tumors, there are going to be many subtypes that are going to come up in the either 2020 classification or the next classification. And if we can potentially identify which are the patients that would benefit from a second operation, I think that would be game changer. And similarly to which patients will benefit from radiosurgery. I mean, there's data in metastasis that some patients may benefit better. And even in one of papers that just came out with radiosurgery in the same journal, demonstrated that some patients may benefit better from particular therapy. So going into the precision-guided therapy for glioma.
On that same token, you guys mentioned, in your sort of presentation regarding sort of, you guys touched upon, sort of using imaging. There's been, I know, some of the work here in New York, the guys are using some like machine learning or artificial AI kind of approaches to look at, vast libraries of MRIs, et cetera, to try to sort of predict, what they're actually, the pathology may be. Is there any work down there that you guys have been doing with radiology to try to better predict just based on imaging alone, or higher Tesla MRI?
We have an advanced brain tumor imaging protocol, but it has perfusion, spectroscopy, diffusion, and many other very commonly used sequences. But there's no one in our group looking into that. There's a big field of radiogenomics, as you know, and hopefully we can, maybe not only with imaging, but combining liquid biopsies where you could potentially do either a CSF or a plasma sample on a patient. And then if that could give you some information in terms of what are you seeing on the imaging. So if you combine both not minimally invasive tests with an MRI technique, that you could increase the the yield of the study. Because in our sample, it was about 15% of patients, but in reality, if you look at the data, about 20 or 30% of patients are being taken back for re-resection in some of the smaller studies, and they found treatment-related changes about 20 or 30%.
So another thing I just want to sort of mention is, as Randy touched on it before, and you guys mentioned, every time you're sitting in these tumor boards, it seems like recurrent cases become this very nebulous sort of discussion where there's no necessarily clear-cut answer. Just based on what you guys present here, what do you guys think is the next step? Where do we go from here? Do you guys already have things in the pipeline that you're looking at, larger studies, whatever it may be, obviously without spilling too many details? Where do we go from here?
Well, I think we have to work together to have better criteria first to report these cases, and that's the efforts being done by neuropathology. And we are starting now to work on sending several tissue samples and sampling that with image guidance so that we can know which parts of the tumor are what. For instance, we can potentially send the enhancement, the non-enhancement, or the flare, and correlate that with path. And that has been done, some work in Colombia from New York before. And, hopefully working on other things. We're working in CSF biomarkers and circulating tumor DNA. And there's a lot of people working, and even in plasma with methylation patterns that are really non-invasive. And with a plasma sample, you can detect a very large number of malignancies.
You guys have done a great job. I mean, I must say that just the sheer number of high quality studies that are coming out of your group is phenomenal. And my hat's off to you on this one as well. I think that you raised the issue of biomarkers, and we've published a few papers on that in JNO, and obviously there's been a lot of interest in that. Are you using biomarkers at this point? And if so, what's the context by which you may use them? I see biomarkers as something that is emerging and likely going to have an appreciable expanded role, but we are not using biomarkers in the setting of recurrent disease at all here yet, although I'd love to see that, and I think we will in the years to come. But what's your practice been with?
Yeah, we're not using them yet for clinical decision, but we're collecting a number of them. So we're doing lumbar punctures in many of the patients and collecting plasma samples. Certainly, I do believe that, for instance, in lymphoma, in less than 5 years, we're going to have a good biomarker. Because as you know, these patients don't benefit from surgery, and you can detect the MYD88 mutation in 60% of the patients. So if you detect that mutation in a patient where you have high suspicious for a lymphoma, it's going to be a lymphoma. Now, obviously, I don't treat the lymphomas. Then it's going to be up to the oncologist to trust and be aggressive with the treatment. And a lot of groups are working with proteomics and microRNA signatures. We're collecting Dr. Ballester, who's a neuropathologist, and he has a lot of interest in CSF. Now we're doing a prospective collection, and not only for gliomas, potentially we have a patient with lung cancer and brain metastases that don't need resection. If we could potentially just do a lumbar puncture, then the patient may not need a lung biopsy and may just go straight to radiosurgery in cases where you don't need to do a resection. And for diffuse midline gliomas, the H3K27 mutation is very well described already. And I think, I don't see many of those cases, or those are in the pediatric population, but I do feel like if you have a diffuse midline glioma and you detect the H3K27 mutation, there's no need to do a biopsy. Now, certainly now we're getting, the yield of liquid biomarker is about 50%. And that's from a study from Sloan Kettering and many other groups. So if you could potentially increase that, and the methylation patterns that the German group has described are potentially going to be even better, because then you're not running into sampling bias, or you can just detect the mutations with a higher percentage.
I think we're going to continue to see great strides, with regard to biomarkers, CSF, blood-borne biomarkers. There's a question from one of the audience members. I'll read it. It says, in your heat map, the gene expression changes were for both treatment-related changes and recurrence, question mark. Does that mean the gene changing are similar in both cases? Also, what about using mass spectroscopy for protein expression changes? So 3 questions, but either of you want to tackle some of those questions from one of our audience members?
For mass spec, there's a lot of potential work to do proteomics or metabolomics. And there's also good data that you can detect IDH. For instance, you can detect alpha-2 ketoglutarate, which is very common in, which is the oncometabolite of in patients with IDH mutant tumors. So that's a metabolite that you can detect, and you can potentially differentiate an IDH mutant from an IDH wild type tumor using metabolomics. And there's not a lot of proteomic work. We actually have a lot of samples, plasma samples from patients at the time of the second surgery. And some of them had tumor recurrence and some of them have treatment-related changes. So, and this is, we've been trying to do this for a few years so that we can potentially find a signature in the plasma of one or the other one, but it's becoming very complicated. The analysis of the proteins is very complicated. And, we have like 15 patients in one group and 6 or 7 in the other group, and we haven't been able to figure out anything. But just collecting samples and storing them from patients, I think that's going to be the only way, and doing multi-center or large group studies to address these questions.
Well, Dana, I appreciate the question, and I appreciate the panelists joining us today. We do try to keep this short and concentrated discussions to maintain the discussions about a half an hour time point. We're closing in on that. So any final comments from our panelists today? I'm sure we're going to see a lot more to come from your group on this, and hope that some of it finds its way into Journal of Neuro-Oncology. Anthony, I'm very impressed. I mean, you have a PhD, but you're obviously still a student at this stage.
Correct. I'm just waiting for match day. I have about 10 weeks left of medical school, and I can say it's done.
So,
good luck. Good luck, Anthony. It's going to go well.
Good luck, Anthony.
Sure, we'll be
students who are on the watching us. I mean, this is the kind of thing that we hope to foster. That is the student-driven publications, and I'm delighted to see that, and glad you got this paper under your belt, and hope to see many more to come. All right.
Well, thank you. Thank you for having us.
My pleasure.
Thank you, guys. We'll be taking next week off for President's Day, but we'll be back in line the following week. Check us out on Instagram and YouTube. Once again, Joshua and Tony and Dr. Sheehan, thanks for joining us.
Thank you, Nick.
See you guys soon. Take care, everyone. Thanks for joining Tumor Talk.
Bye-bye.